Good morning, everyone. So, monitoring of sedation and analgesia in ICU. Why is it important? So, this is basically a basic quality indicator for any ICU, and it also forms a major factor in patient safety parameter. And pain is considered as the fifth vital sign, apart from heart rate, respiratory rate, blood pressure, and
Can we have
temperature.
the audio a little better?
Pardon?
No, them. Can you get the mic a little closer? Both of them.
Yeah.
Yeah.
Thank you, sir. So it also forms a part of FASTag which we follow daily, and it is assessed in various accreditations like JCA, NABH and all. So basically we have to maintain the patient in a calm, composed, coherent way in our ICU. If it is not addressed properly, it will lead to increased length of stay and mortality in the ICU. So consequences, if the pain analgesia is not addressed, pain can cause increase in the stress and sympathogenic stimulation, causing increase in the heart rate, tachycardia, hypertension, leading to increase in myocardial oxygen demand, and susceptible patients may lead to coronary ischemia also. So pain in abdominal incision patients may lead to diaphragmatic weakness, leading to atelectasis and pneumonia. Some psychological complications like agitations, delirium also may, if it is not addressed, if it can lead to that. And psychological sequelae like chronic psychological sequelae like post-traumatic stress disorder, delirium, or depression it may go into. And pathologically it may lead to systemic inflammatory response syndrome, hyperglycemia, hypercoagulability, impaired wound healing, immunosuppression. And finally, it will lead to increase in the length of stay in the ICU and mortality. There are various predisposing factors and causative factors which will lead to anxiety, delirium, and pain. So these are all our day-to-day factors, like any procedures like intubation. Before intubation, we have to give analgesia properly. If not, the patient will recall and come back and inform you. And any procedures like small procedures like suctioning, central line insertion, all those things also can lead to pain. So before giving chest physiotherapy or suctioning, give a bolus of analgesics or sedatives. Other medical underlying or surgical illness can also lead to pain. And hospital environment itself can lead to the stress and anxiety. So address these pre-existing illness or predisposing factors before, and then go for symptomatic treatment with a sedative for anxiety, and pain addressed with a analgesic and antipsychotic for delirium. So identify the cause for patient distress. Apart from these three, patient might be suffering from dyspnea. Address the cause and treat that. Or if you are paralyzing the patient without any sedation, also can cause distress to the patient. So how to monitor the sedation? There are mainly we have clinical assessment models and objective models. Clinical assessment models, we have Ramsey sedation assessment scale, sedation assessment agitation scale, and Richmond agitation sedation score, Vancouver scale, Minnesota MSAT scores, and ATI's instruments. So Ramsey sedation score, it is best known and very commonly used in our ICUs. And the main disadvantage of this is we use the loud stimulative stimulus or globular tap to assess the patient, and when the patient will come to very much awake, and we may need it to give some sedations to compensate for that. So it goes like this. If one indicates patient is awake and anxious and agitated, 2 indicates calm and cooperative, 3 patient is drowsy, responds to the commands, 4 patient is asleep, but he responds in a brisk way, and 5 he responds in a sluggish way, and 6 there is no response to any noxious stimuli. Response agitation sedation score, in which 0 indicates patient is calm and coherent, plus parameters indicates the agitation scale, minus parameters indicates the sedation scale. So -1, the patient is drowsy, but when we call his name, he will have a sustained eye-to-eye contact for more than 10 seconds, and if the eye-to contact is less than 10 seconds, it is called as -1, and -3 if he is in moderate sedation, there is no eye-to-eye contact, and -4 is only to the deep stimulation, -5 is no response to the deep stimulation also. And in the agitation scale, +1 means patient is restless, +2 is agitated, he will be fighting with ventilator with coughing and all. And +3 is very agitated, and he may pull out the catheters and very aggressive also. And +4, he is combative, dangerous to himself and dangerous to the staff over there. Objective parameters, we have EEG, bispectral index and responsiveness index. So EEG is basically a plot of voltage versus time. It mainly considers the amplitude, frequency and the patterns of the waveforms alpha, beta, theta and delta. Alpha indicates conscious relaxed state. And the analysis of EEG is mainly by time domain parameters and frequency domain parameters. Both time domain parameters and frequency domain parameters does not have any correlation with the depth of sedation. So we came to the bispectral index, which considers both time domain and frequency domain along with neural network data analysis, wherein the data will have almost 1,500 anesthetics with different depth of sedations and different dosage. So based on that, it will give a single number starting from 0 to 100, and anything for general anesthesia we will keep around 40 to 60. Our ICU levels, moderate sedation considers it to be around, it should keep around 60 to 80. And it has a very good correlation with modified Ramsay sedation scores. So practicalities, it is not very cost effective, and it has very good correlation with, it is when compared to the clinical assessment models in a patient on ventilator, it does not have any good results or any benefit over the clinical assessment models, and it can be disturbed with the unipolar diathermy and all. Usually it lags behind few seconds compared to the clinical assessment models. So this is the figure wherein it shows the BIS monitoring index. In the responsive index also, we'll have the same leads on the frontalis muscle, wherein we'll monitor the EMG of the frontalis muscle, and whenever the patient becomes awake, the EMG activity of the frontalis muscle increases. So it also gives a range from 0 to 100, wherein 0 means unresponsiveness and 100 means fully responsive patient. So after assessment, we will give the sedation and plan the protocol of sedation with an initial bolus followed by an infusion of sedative or analgesic medication, and then titrate according to the repeated monitoring every 4th hourly. So coming to the depth of sedation, whether we go for light sedation or like deep sedation or not, we will go through that. So our aim is to keep the patient calm, composed and coherent. So we should not oversedate the patient or undersedate the patient. Oversedation leads to increase in length of stay in the hospital, increase in length of stay in the ICU, and increased duration on ventilator can lead to the complications like VAP. And undersedation will lead to self-extubation requiring reintubations, and patient may recall to the events whatever happens, and requirement of neuromuscular blocking agents also increases, and delirium increases. So we have to decide between light sedation or deep sedation. So there was a study conducted which compared between light sedation group and deep sedation group. There was no mortality benefit which was with light sedation compared to the deep sedation, but there was reduction in the ventilatory days with light sedation compared to deep sedation, and there was reduced tracheostomy requirement also in light sedation groups, but there was no difference in the delirium or post-traumatic stress disorder and all. So light sedation is recommended with grade 1B recommendation. Avoid deep sedation until unless the patient has severe ARDS, or if he is having increased intracranial pressure, or if he is in status epilepticus. So there was a study which compared between protocolized based or assessment oriented protocol based sedation versus usual care of sedation. In that, protocol based sedation has reduced sedative requirements, and duration of mechanical ventilation also has reduced, and length of stay also in the ICU also has reduced. So the recommendation is to follow assessment driven protocol based sedation with stepwise approach for pain and analgesia and sedation management in ICU. So they also recommend analgo sedation. Analgo sedation is either analgesia based sedation or analgesia first and sedation next. So analgesia based sedation is, for example, we have a opioid which has both the properties of sedation and analgesia, which is recommended for sedation in ICU. So analgo sedation is recommended. What is daily sedation interruption? So we have to stop the sedative medications for a few hours every day, keeping the patient more awake, responding to the commands with a RASS score of -1 to +1. So whether there is any benefit with that, in 2000 there was a study which showed reduction in the duration of ventilation with daily sedation interruption or spontaneous awakening trial, DSI. So there were some caveats in this study also. They used benzodiazepine, which is no longer recommended, and they also awake the patient from deep sedation to light sedation, wherein deep sedation is no longer recommended. So in another study among 430 medical and surgical ICU patients in Canada between 2008 and 2011, there was a randomized control trial conducted between protocolized sedation versus protocolized sedation with DSI, daily sedation interruption. So there was no benefit found between the daily days of extubation or duration of mechanical ventilation, ICU stay, length of stay or hospital length of stay or ICU mortality or delirium rates. And there was another Cochrane analysis which compared between daily sedation interruption versus no daily sedation interruption. In this also there was no difference in the mortality or length of stay in the ICU or mechanical ventilation or delirium in the patients in the other studies which they quoted. In ABC trial, along with spontaneous awakening trial, they combined spontaneous breathing trial in the intervention group and only spontaneous breathing trial in control group. So there was, they found that there was a mortality benefit when combining with spontaneous awakening trial with spontaneous breathing trial compared to only spontaneous breathing trial. So they also found there was less duration on mechanical ventilation and lesser ICU stay also by Gerard et al. So they formed a bundle by combining spontaneous awakening trial with spontaneous breathing trial, and the bundle was ABCDEF bundle. A means assessing the pain and treating the pain. B is combining both spontaneous awakening trial or DSA with spontaneous breathing trial, and C is choose of analgesia and sedation. D is delirium management assessment. E is early mobility, and F is family engagement. So this was a study conducted in almost around 15,000 patients, wherein they followed the ABCDEF bundle and the compliance to that, wherein the complete performance is considered as a 100% compliance to all the components of the ABCDEF bundle, and proportional performance is considered as percentage of each component in the bundle followed as percentage they have taken. So they found out that there was an increased survival benefit and less coma, incidence of coma and delirium, and requirement of physical restraint also has reduced, and shorter ventilatory days and fewer ICU readmissions. So as the percentage of compliance increases, the ICU readmissions also have reduced, and as the percentage of compliance to the bundle increases, the mechanical ventilation duration, coma incidence and delirium incidence also has reduced. So how to choose a medication among the sedatives? We have dexmedetomidine, benzodiazepines and propofol. So this was a study meant randomized control trial in which they stratified between septic patients and non-septic patients. In septic patients, there was a benefit with dexmedetomidine with increased delirium-free days or coma-free days and mechanical ventilation-free days. And in midazolam products study also, there was reduced duration with dexmedetomidine group compared to midazolam and propofol. So minimize the use of benzodiazepine, and dexmedetomidine and propofol is advised as a grade 2B recommendation, and opioid-based analgesia and sedation is recommended. So pain is considered as a fifth vital sign, and it is monitored by visual analog scale starting from 0 to 100. 0 means no pain, 100 means maximum pain. Numerical rating system, that is 0 to 10. 0 means minimal pain and severe pain, and verbal rating system, mild, moderate and severe and absent pains. And in a patient who is not able to communicate, behavioral pain scale and critical care observation tool is used. And behavioral pain scale considers facial expressions, whether he is tight or grimacing and all, and upper limb movements, compliance to the ventilator. Another 30 seconds, sir. So apart from these three parameters, in CPOT scale, we also use the muscle tone and occasion in case of extubated patient taking the history of the pain and all. So these are the objective indicators. NRS scale has a better success of assessing the pain and better sensitivity compared to VAS score. So as soon as like when we first we have to assess the sedation by RAS score. If it is less than 0 and if the RAS score is -4 to 5, intubate the patient and assess the pain. And if the patient is calm and alert, assess the pain directly. If the patient is agitated, give a sedative and then assess for the BPS score. If the BPS score is high, then give fentanyl along with propofol. So the adjustment of drugs in case of hepatic and renal dysfunction. Remifentanil is indicated in hepatic dysfunction, and we have to modify the dose of morphine and oxycodone in case of renal patient. Thank you.
Thank you very much, Dr. Ramesh.